All right. Thanks everybody for coming. I think we'll go ahead and get started, at least with the introductions, since it is 3:30 and we want to stay on time. So for folks who are new to the CFAR seminar series, the CFAR seminar provides a forum for presenting and discussing state-of-the-art research findings in HIV pathogenesis, virology, care, and treatment, and to provide an opportunity for communication and collaboration across the HIV/AIDS researchers in the 5 CFAR affiliated institutions and their partner organizations. Today is the first in-person CFAR seminar for this year. So I'm very excited to introduce 2 amazing speakers. Our first speaker is Dr. Adrienne Shapiro. She's our New Faces speaker. Dr. Shapiro is an assistant professor in global health and infectious diseases at the University of Washington. Her research focuses on the epidemiology, prevention, and treatment delivery for 3 of the leading causes of global infectious disease mortality: tuberculosis, HIV, and COVID-19. Her research interests include prevention science and diagnostics for TB, particularly in people living with HIV, in HIV prevention and care cascades, and COVID-19 prevention and treatment, including for people living with HIV. Dr. Shapiro has multiple collaborations across South Africa, Cambodia, and the US, and her work spans diverse approaches, including clinical trials, implementation studies, and observational epi. She prioritizes research that addresses disparity in access to diagnosis, prevention, and good clinical outcomes for TB, HIV, and COVID-19. Dr. Shapiro, thank you so much for coming. I'm excited to hear your talk.
Thank you so much, and thank you for inviting me to be a speaker as part of the New Faces series. I'm grateful to the CFAR for the opportunity. These are my disclosures. So just to start with a brief roadmap for my talk today, I'll start off with a little introduction of my motivation. Why am I interested in TB screening and prevention for people living with HIV? And then I'll talk about 3 studies briefly, 2 of which were done with the support of a CFAR New Investigator Award, talking about novel diagnostics and tools for TB screening, and intervention to deliver TB preventive therapy for people living with HIV in South Africa, and hot off the press, preliminary results of a study looking at TB and COVID-19 in South Africa. And then we'll touch on some future directions before turning it over to the seminar speaker. So this is a CFAR session. You're probably all looking at your watches and checking the site. Am I in the right place? Why aren't we talking about HIV? Why are we talking about TB? And why South Africa? Well, TB is the leading cause of death for people living with HIV globally. So we can't really talk about reducing HIV mortality unless we talk about preventing TB morbidity and mortality. And South Africa has among the highest incidence of HIV, the highest incidence of TB, and the highest prevalence of HIV in people with TB worldwide. It's really the epicenter of the overlapping epidemics of TB and HIV. Despite substantial progress in research over the last several decades, there remain significant gaps in identifying and diagnosing TB, particularly in people living with HIV. And although we have many interventions for TB prevention, there are substantial gaps that remain in delivering TB prevention interventions to people who need them. So I'm going to be talking about TB prevention science, which is what I spend my time thinking about, talking about, working with. And it all centers around this cascade of the TB prevention cascade. So the way I conceive of the TB prevention cascade is people who are at risk for TB are screened. People who have a positive screen go on to receive a diagnosis, and people with an affirmative TB diagnosis are then treated, both to benefit the person with TB, to provide curative treatment, and to serve as further prevention, treatment as prevention for TB, to prevent ongoing transmission of TB and other infections and deaths. Conversely, people who are screened and are at risk for TB and screen negative for TB, many people should go on to receive TB preventive therapy, or TPT, to avoid developing a TB disease. So there are many barriers along this pathway, ranging from poor uptake of screening, lack of diagnostic tools. And one of the consequences of these is that we have what the WHO calls the missing millions. Really, it's not the people who are missing, it's the health system misses up to a third of diagnoses of TB cases worldwide every year. And that means that these are people with TB who do not receive a diagnosis, are not notified to public health systems, and may not receive treatment. The WHO and many national TB and HIV programs have very clear evidence-based guidelines that all people living with HIV should be screened for TB, and for people who don't have TB disease should be given TB preventive therapy. In addition to people living with HIV, other populations at risk for TB at elevated risk should also be screened, and some of those populations should get TPT as well to prevent both their own TB and spread of TB to people who are particularly vulnerable, including people with HIV. So to do all of this screening, prevention, treatment, diagnosis, we, the global community, we have okay tools for diagnosis, prevention, and treatment, but what remain are really substantial gaps in implementation. And there's a real need for better tools and better implementation of the tools that we have. I showed this chart as just a little perspective taking the toolkits that we have for TB, HIV, and COVID-19, and the timeframes in which we've developed these toolkits, just as a way of highlighting where the big gaps, particularly with TB, are. So most essentially to this entire cascade is having a rapid point of care diagnostic test. It was game changing for COVID-19 when we were all able to swab our own noses, get a diagnosis on a strip, and make decisions about whether we should isolate, get treatment, and prevent onward transmission through maybe better mask wearing. I won't get into the details of the implications, but suffice to say, it was game changing. It was similarly game changing for HIV when there's a point of care finger stick blood test that can tell you in 25 minutes, does this person have HIV or not? And if they have HIV, they can go on to receive treatment. If they don't have HIV, maybe they're eligible for PrEP or other preventive therapies. For TB, we don't have a rapid point of care test. It remains very difficult to get an accurate microbiologic diagnosis that says you have TB, because the best tests that we have are still very expensive, require expensive equipment. Either they are expensive or they take a lot of time or both. And most TB tests rely on a cough sample, a sputum sample, which is not the easiest thing to work with. A nose swab for COVID, a finger stick blood test for HIV, much more straightforward and easy to obtain than a cough sample. Excuse me. And just briefly to review with TB, we do have an oral preventive treatment, which we also have for HIV. We have an oral curative treatment. We don't have a long-acting treatment. So TB treatment is 6 months, at least 6 months of daily antibiotics. With HIV, we now have a long-acting injectable, both treatment and prevention. TB does have an oral preventive treatment, but it ranges between 1 to 6 months. So we could be doing better with that. Long-term adherence is required for both TB treatment and prevention. And also, most notably for both HIV and TB, we don't have a highly effective vaccine. With COVID-19, within 12 months of the identification of the virus, we had great vaccines that were highly effective at preventing mortality and hospitalization. It's been 40 years since the start of an HIV attempted a vaccine, and 150 years since the TB bacteria was first identified under the microscope, and we still don't have a highly effective vaccine. So moving on to talking about some work on novel diagnostics and tools for TB screening for people living with HIV. We talked about how sputum samples, these cough samples, are really a terrible sample to have to work with, and there's no good point of care rapid diagnostic tests available for TB. There's a lot of effort to try to improve diagnostic tests to shrink that gap, that diagnostic gap, reduce the number of missing millions, with a particular focus on non-sputum based tests. There is a test that uses urine to look for a part of the TB cell wall called LAM. But the current test, which is here, it's a dipstick test, it's only about 20 to 40% sensitive, so not really ready for prime time. So are there other ways that we can improve upon that test to have a better chance of obtaining a TB diagnosis? So we worked with a bioengineering group called SALIS, who had developed a next generation product that concentrates LAM from urine and uses a lateral flow assay to detect the LAM from concentrated urine. And working with PI Paul Drain and Doug Wilson, based in South Africa, and his team, we tested and did the first in human studies to test the diagnostic accuracy of this next generation urine-based TB diagnostic test. So we compared how well this test performed against a standard of care reference diagnostic for TB, which was GeneXpert or TB culture. So with the 93 participants we enrolled, 76 had TB by reference testing, 17 were TB negative by reference testing. We found that the concentration component of the Salus device improved LAM detection twofold, and the full test kit was ultimately 80% sensitive for diagnosing active TB in people with HIV and had 52% sensitivity in people without HIV. So with these encouraging initial results of a novel test using a non-sputum-based sample, we expanded the platform for diagnostic investigation in South Africa, both to test further iterations of the flow TB urine test and other diagnostic tests and biomarker combinations. And we did this through the PROVE TB study cohort, which is a cohort of adults in South Africa. Again, Paul Drain is the PI of the study. We continue to work with the Nkuseli group in KwaZulu-Natal. And in addition to testing the flow TB tests, we also tested other TB diagnostic tools, including working with Jerry Cangelosi, pictured here, and his group, who have really advanced work on using oral swabs to detect TB. So tongue swabs to pick up TB DNA from the tongue, amplify using a PCR-based diagnostic. And we were able to show that combining urine LAM testing and oral swab testing both increased the sensitivity compared to each individual test alone without getting a hit to the specificity. So, we saw, this is a graph that shows the overlapping of the tongue swabs, the urine LAM, and then the reference testing. And the combination of tongue swab and urine LAM picked up almost all of the TB reference tests, except for a few that weren't picked up by either. Sorry, a few here that weren't picked up by either. And this really moves the field forward to say that, yes, we can, through either combination testing or through improved, like further iterated and improved novel testing methods, get at better TB diagnosis in people who maybe can't produce a sputum sample to be able to get that sample to begin with. These are symptomatic people, yeah. And we're continuing to work with Chandler Church, who is a recent UW ID fellowship grad who's now working at the HVTN, to do a review of the existing literature on other oral swab assays for TB diagnosis, to see what the state of the field is and where we can take that forward to further optimize both sample collection and detection optimization. All right, it's a whirlwind tour, I promise. We're going to go now to TB prevention and how to improve TB preventive therapy coverage. So we've talked about how there are global guidelines that say that people with HIV should receive TB preventive therapy. We know that this reduces morbidity, mortality, and actually overall mortality in people living with HIV in high burden settings. But despite these recommendations, the WHO has shown that in the Africa region in 2017, only 32% of people living with HIV who are entering care received TB preventive therapy. In South Africa in 2018, only 65% of people living with HIV entering care received TB preventive therapy. And at that time, the major available regimen of TB preventive therapy was a 6-month course of daily isoniazid. There are a number of reasons for these big gaps in uptake of TB preventive therapy, ranging from the fact that the initiation algorithms are complicated, clinicians at HIV treatment visits have a lot of competing priorities, TB prevention often falls to the side, systems don't make it easy for clinicians to have stock of drug on hand and provide it to patients, and there's a substantial amount of under-resource at the health system level. So we wanted to ask, could we use a different delivery method of TB preventive therapy to overcome some of these barriers that are experienced in clinic-based delivery settings for TB preventive therapy, or in this case, isoniazid preventive therapy? We decided to answer this question by embedding a study within an ongoing study called the DUART study, led by Dr. Rand Barnabas, which was a randomized controlled trial of antiretroviral therapy delivery, with the primary goal of looking at virologic suppression at the end of 1 year in people who received ART through one of 3 different delivery mechanisms. So we embedded TB preventive therapy delivery along with the package of HIV treatment. So for the DUART study, people living with HIV were identified in the community, and they were randomized to either a standard of care group where they would initiate ART in the clinic and then receive ongoing monitoring and resupply in the clinic as per the national guidelines. A fully community group where people identified with HIV in the community would actually start their HIV treatment at home or at a community mobile van, and then continue to receive refills quarterly with a mobile van delivery, maybe never setting foot in a clinic unless they were ill outside of a study visit. Then there's a hybrid group where people initiated ART in a clinic, but once they initiated ART, then they were returned to the community and could receive all of their ongoing refills and follow-up in the community. So IPT initiation and monitoring resupply followed the ART supply as well. The study was conducted in 2 regions of KwaZulu-Natal province in South Africa, a peri-urban region outside Pietermaritzburg and a rural region up in northern KZN. And at this time, the HIV prevalence in KZN was 36% in adults. The TB prevalence in South Africa at the time was 852 per 100,000, which I believe was the highest in the world at that time. And we knew from a previous study that IPT uptake for people with HIV in this region was about 18%. Enrollment for this study began in 2017 and enrollment ended in 2019 with a 12-month follow-up. In the study, HIV testing was conducted in the community with a mobile van, and eligible participants had screened negative for TB and were clinically stable at the time. In the community-based ART group, nurse-delivered ART was administered at community visits and IPT bundled with it. A mobile app prompted refills for both ART and IPT, and the study was conducted in close partnership with the Department of Health clinics. Clinic-based ART groups would typically go monthly for refills to the clinic, and everyone, people may have proceeded to receive ART every 2 months, but while people were receiving IPT, they typically had to still go every month just for the IPT. This is another schematic showing the dispensing procedure. So people would enroll, and in the community group, at the month 1 visit, they would receive their starting IPT package. At month 3, they would get a 3-month supply of IPT. At month 6, they would get their last 1 month, so that finishes the 6-month course. And then if at any point people hadn't started on schedule, they could get catch-up initiation of IPT at a subsequent visit in the community or the hybrid arms. So what did we see? Let's start looking at the percentage of people who initiated IPT in each arm, the red bars. So this is the clinic-based arm. We see that about 20% of people who made it to the clinic to start ART initiated IPT as well. In the hybrid arm, 48% of people who initiated ART also initiated IPT. And in the community-based arm, where nearly 100% of people who were randomized started ART, 90% of people who started ART also started isoniazid. We also looked at continuations of where people collecting their refills of IPT either at the clinic or in the community arms. Again, in the clinic-based arm, only 48% of people who started IPT had any evidence of getting a refill dose. In the hybrid arm, 84% of people who initiated were seen to continue. And in the community arm, 89% of people who started IPT had multiple refill pickups. So we see that in the community arm, there's a substantially, almost 5 times increased IPT initiation compared to the clinic arm, and nearly more than 2-fold in the hybrid arm. And then adherence, continuation was also equivalent to the community and hybrid arm, and almost 2-fold higher than in the clinic arm. So we know that innovative ways of delivering medication can improve uptake of essential interventions like IPT. So now we're going to switch directions a little, and this is research that was conducted in the heat of the COVID pandemic. So what we know about TB in South Africa is that there's a really high prevalence of TB infection in South Africa. Most TB disease is reactivation of an infection that most adults have by the time they're 30. And particularly TB in people living with HIV, and the majority of it is reactivation disease due to immune suppression from HIV. Similarly, we know that COVID-19 as a condition causes immune dysregulation, including immune suppression and early infection. And we know that COVID-19 increases the risk of many acute and chronic immune-mediated conditions like diabetes and subsequent lung infection. So we asked and wanted to know, does COVID infection increase the risk of TB reactivation? We also saw epidemiologically that during the first couple of years of the COVID pandemic, there was a lot more, well, there was first a drop off in diagnosis of TB. That was probably due to people not getting to a facility to get a diagnosis. But in the last year, there was a big uptick in cases of TB. So really, there are a lot of motivating features to ask this question: does COVID increase the risk of TB reactivation? And why do we care? Well, if COVID increases the risk of reactivated TB disease, then that would suggest that providing TB preventive therapy to people who have COVID would reduce this risk of reactivation of disease. So we had the opportunity with the PROVE cohort to test this, to ask this question and test this hypothesis. The PROVE cohort was enrolling people with and without TB and collecting samples during the first year of the pandemic between 2020 and 2021. And this was really an opportunity to study the TB risk in people with and without SARS-CoV-2 infection. So we found that 333 adults who enrolled in the cohort between May 2020 and December 2021 in South Africa were as part of the PROVE cohort. All of them had TB diagnostic testing as part of enrollment. That was the point of PROVE. They had a gene expert and a TB culture, and those were what identified microbiologically confirmed TB. Every participant had blood collected at enrollment, which was stored frozen at -80. And we sent blood samples from the biorepository to Maria Lemos at her lab here at Fred Hutch, who tested the blood samples for SARS-CoV-2 antibodies. So we were able to see what the prevalence of prior SARS-CoV-2 infection was in people who were diagnosed with and without TB. So this was our population. This is what we saw. We had 81 people with TB, 252 people without TB, more TB in men than in women. Age was reasonably evenly distributed across the two groups. Clearly, the people with TB were a little bit sicker. They had lower median BMIs. The people with HIV had lower CD4 counts. This HIV positivity was a feature of the enrollment. So only people who had a gene expert positive result were enrolled if they were HIV negative, whereas we enrolled prospectively anyone with HIV and with symptoms. So that's not a that's an artifact of the recruitment. Maria Lemos tested the stored samples for 3 COVID antibodies: anti-spike, anti-nucleocapsid, and anti-spike from the beta variant, which was predominantly circulating in South Africa. So the upshot of our finding, what did we find? Was there any difference in prior SARS-CoV-2 infection in people with and without TB? Regardless of how you defined prior COVID infection, the answer is no, there was no association. So if we defined prior SARS-CoV-2 infection as any of the 3 positive antibodies, there was no difference in TB positive or negative. If we defined it as requiring all of the antibodies to be positive, still no difference. So we've concluded that COVID does not increase the risk of TB reactivation. Still a preliminary result. We're going to do some more digging and more controlling, but I think these are really solid equivalent percentages. So I'm pretty confident that this is what the final result is going to turn out to be as well. So what are the future directions in the field? Well, instead of 6 months of daily isoniazid, there are shorter courses of TB preventive therapy. And so we're asking questions of how to deliver shorter courses more easily to make it easier for people to take TB preventive therapy. We desperately need better tools than these 1 to 3 to 6 month courses of oral therapy. We need a TB vaccine. Very excited that an HVTN protocol is going to start enrolling in South Africa in a few months. And we're really looking forward to results from that. And we also need better tools for monitoring preventive therapy while we are still using it. And working with Dr. Asa Tapley, who has received a CFAR International Pilot Award to look at a urine-based test that monitors ingestion of preventive therapy. So that's another exciting part of this work that I'm looking forward to doing with some of our partners from the previous studies. So I think I've summarized my conclusions at the end of each of the little sections. And I want to take this moment to thank the many collaborators, mentors, and funding support that I've received from both the US and South Africa, particularly here at University of Washington and the Fred Hutch and partners in South Africa at HSRC, RE, and in KwaZulu-Natal. And with that, I will end and open for questions.